Afternoon, everybody, and welcome to the third QI Connect for 2019. I'm Jason Leach. I'm the National Clinical Director of the Health Service here in Scotland in what is unfortunately a relatively cold and wet Glasgow. I hope you're having nicer weather. We've gone from 25 degrees to 12 degrees in about 2 days. So QI Connect, as all of you know, represents an opportunity for colleagues across the world now and around health and social care and other areas of our public sector to learn from international leaders in improvement, innovation and integration. So welcome. I'm now going to pass briefly to Jess, who's going to take you through some of the new, fancy, technical elements of the new WebEx, which has probably already confused some of you. It certainly confused me briefly, but we think we're there. So Jess will talk you through a little of that.
Hi everyone. So we've had an upgrade to the WebEx today. So these are just a couple of housekeeping slides to get us started. To use the chat box now, you'll see at the bottom of the screen that there's a speech bubble circle, and if you just click on that should give you your chat box at the side, and it will also give you your list of participants. Now, for the annotation tool, we'll come to that in a second. What we're doing now is on the left-hand side of the screen, there will be a grey oblong, and the second icon down is a squiggle shape. Now, if you click on that, it will bring up another list of tools alongside it, and it's the top one is the arrow, and you just click on that. So if we just move along to the map of the world, we'll just test that now. If you just want to click on where you're joining us from today, so you're clicking on the squiggle and then the arrow. Excellent. We've got quite a few people, Eileen Holmes, Alistair Kirk, Gordon Skilling, Frank, there we go. That's great. That's good to see that you've got the hang of that. Okay. So I will just hand you back to Jason.
So if that doesn't work for you, feel free to chat into the chat box and we'll try and help you. So for clarity, the images we had don't bear any resemblance to how it now works. So if you hover to the left of the map, you'll see a grey oblong. Click on the squiggle, and then another set of tools appear, and you're allowed to then click on the arrow, and that lets us know that Simon Mackenzie's in London, Dominic Allwood is in London, and Frank Federico's in Boston. It also suggests I'm in the Western Isles, which I'm not. I'm in Glasgow. So we now have over 1,000 QI Connect organisations from around the world who connect either live or listen in afterwards, and we're really fortunate to have many of them on today. So we traditionally, at the beginning of these events, have a little competition for somebody to win what is a very, very rare prize now. There's only, I think, 4,500 of them left in a big cupboard in Healthcare Improvement Scotland, and that's a QI Connect mug. So when I click the next slide, which I will do in a second, the first person to click the flag of the country I will say as I click it wins the prize. Does everybody understand? So I'm going to click to a slide of lots of flags. I'm going to tell you the country. The first name that appears on that country wins the prize. Michelle is paying attention to see who is first. And the flag we want you to point to is Sweden. Oh, Dominic Allwood. Oh, much as it hurts me, we're going to have to send Dominic Allwood, who's probably either in the Health Foundation or in Imperial, a QI Connect mug. We'll make sure you get that done. Jackie Welsh was just seconds behind. There is an image of the mug you'll be receiving. So very briefly, before we get to the main event, 11 new organisations involved this month and joining us today. So you can see from there the Ministry of Health in Saudi Arabia, the Manchester University Foundation Trust. You see some of the others in that group. Every Scottish board, you won't be surprised to know, is now participating, and 77 academic institutions from around the world, 77 universities from around the world. You can listen again both to this one if you like what you hear. You can listen to previous ones. You can listen to last month's and some from last year, as you see on that little list. If you go to the website, we'll be delighted if you share them both with yourself and with maybe your groups. A couple of quick shout-outs to ISQA and to the Q community. We are now a partner of both of those organisations. So the QI Connect series now features in ISQA's fellowship programme, and the Health Foundation and NHS Improvements work in Q. There's now 50 members or more, I think, in Scotland of that Q community, and many more around the world, and QI Connect becomes part of that curriculum. That's the crowd who have brought you and done most of the hard work, except me. And then at the end of this, when we hear from Frank in a moment or two, we're also going to hear from Arvind, who is known to many of the Scots as our clinical lead for SPSP medicines in Healthcare Improvement Scotland. And Arvind will ask Frank a question or two right at the end before we move on to other questions from the crowd. If you want to involve yourself in social media, then this is how you do that. We have some people watching, some people tweeting as we go along, but please feel free to do that. The hashtag is #HISQIConnect, and the HISQI Connect also has its own account, so if you copied them in, then that would be great, and we'll be able to retweet you. We'll also have questions at the end, and if you ask questions as you go, we'll monitor the chat box, so please do that if you possibly can, and we'll include some of them for Frank at the end. So, breathe. So we're really honoured today to have Frank Federico speaking. Frank is one of the dominant voices in the world on patient safety and travels globally to talk, to teach. I learned patient safety from Frank Federico and a couple of other people, but there are few people in the world who understand safety in a deep and meaningful way like Frank does. He has experience both in Scotland, in the Middle East, in North America and other parts of the world, and we're delighted that Frank's given up some of his day today to come and speak to us. So Frank, you have the ball and you have the crowd.
Jason, thank you. And in the spirit of all teach, all learn, I also learned from you and many of the people in Scotland about the great work that you've done. And some of what I'm going to talk about today is a compilation of the work that IHI has been doing now for over 25 years, and how much of that has come from the work that we've done with organizations like the hospitals in Scotland, like NHS Scotland and others in improving safety. I'm going to start talking about the framework for safe, reliable, and effective care, which is the foundation of the work that we're doing. However, before we do that, I always want to start with talking about culture. And we talk about the culture of safety in an organization. And the more and more we talk about this and the more we think about what work is going on in an organization, we may actually be doing a disservice by highlighting and calling it only a culture of safety. It really is the culture of the entire organization that puts patients at the center and makes sure that all of the work that we're doing, and this is throughout the healthcare system, it's not just in the acute care, that is the culture that says we are here to provide the best care possible for our patients. However, that culture really is the behavior and the values that people have. So there are many definitions of culture. It's what people do when no one is watching. That is, that you hold yourself accountable to making sure that you are acting and behaving in a way that is consistent with your values. If, however, you don't do that, then that means you're not really practicing that culture and you're not really living it. Ultimately, what we've learned through a lot of our work, that if you don't have trust, that is trust in each other, trust in patients, trust in the work that we do, it becomes very difficult to build any kind of a culture. So I'll really focus today a lot on the whole framework and how we have to have trust as the foundation for all of that work. This is our framework. It is depicted in a circle. However, the reality is that it's really not a circle. It's more of a weave. That is, if you think of the fabric of the cloth that is making up your shirt or your pants or whatever you may be wearing today, it is only as good as the threads that are used as well as how they're woven together. And in an organization, to be successful, you don't work on just any one of these and there's not a sequence. You actually wind up working on all of them, and together they reinforce each other. I'm going to focus primarily on the upper part of the circle, the culture component today, because in that is what we've learned is necessary for continued success. In the work that we've done, for example, during the IHI campaigns, we developed bundles of care, for example, the ventilator care bundle. Much of the work that we did in Scotland was based on the different bundles and the different elements of care that we delivered. What we learned, however, is that if all you've done is implement a bundle and you really haven't changed the condition under which people work, if you haven't changed the behavior and the values under which people do, all you've done is implemented a bundle. The success of your organizations as well as others around the world is really predicated on the fact that not only have you fixed the systems and the processes, but you've affected how people think about the work, how people affect themselves, and how they work with each other. The first starts with leaders. Leadership is what leaders exhibit. And for us, leaders are at every level of the organization, and there are people who don't have titles of leaders who are leaders of an organization. That is, these are well-respected people, people who, if they say and do something, others will follow them. Leaders are responsible for behaviors. That is, the behaviors that they tolerate are the behaviors that affect the culture that you have. They are the guardians of the learning system in the sense that they are responsible for ensuring that there is a learning system, there is an improvement method, there is transparency in what we do, and they're also responsible for shepherding the culture of an organization. Foundational to the culture is psychological safety, the ability to speak up, the ability to share your concerns and not feel that you are going to be put down or ridiculed for what you're saying. We find that psychological safety is so important in any of the work that we do, and also psychological safety for patients to be able to speak up and feel that they are being listened to and not being ridiculed. Accountability is the next component, and accountability, especially here in the United States, has a very negative connotation. Matter of fact, I was sharing the framework with a group of international physician leaders, and there were a couple of psychiatrists in the room, and they said, "Oh, change that word quickly because people will be turned off by it." So yes, we can change it to responsibility, we can change it to ownership, but ultimately the message that we're trying to give is that when we talk about accountability, we're talking about that people know their job and they do their job and they do it really well. And secondly, when something happens, that we have a fair and just method of analyzing what happened and where the breaks in the system are, whether or not there is a certain level of personal accountability in that, whether or not it is just solely system. And usually in a fair and just culture, we find that it's a blend. It's never one or the other. It would be too easy if it's just one thing or another. Teamwork and communication is also a critical role in ensuring that you have a culture that reinforces improvement. And by that we mean that you have people that work together well, people that communicate with each other, people that are able to solve problems together. We've added a block called negotiations, and really that's more of one of our terms, but it really means engaging others. That is, as you think about working that you do, we are in a team sport. We do have to work together. We do have to engage our patients and the users of our services. And how we do that and how we get people to work together on a common goal becomes really the nature of being able to get the work done. And there's a whole science around engagement and negotiations with others. And I think that every day in our work, this is what we do and this is what we're facing. And those of us who know how to do it well are able to get people to help and be part of the process. However, foundational to all of that in the framework is that trust that I talked about. Because without it, I don't think that we can work on any of those elements and work together. And also, how do we find the opportunity to work together if we can't communicate and trust each other to be able to do the work together? In order to shape culture, and you notice I didn't put safety here because I mean all culture, is the understanding of what culture is. And culture really starts with not only what is going on in the workplace, but what is on the world around you. What is at the trust level or at the corporate level? What is at the unit level? Because each of those are microcosms of the trust that exists. And of course, the culture starts with you in the middle, because your behaviors and your attitudes are going to impact and influence others. The reason I think it's important for us to understand the culture that exists is that as we try to move into a culture of continuous improvement, a culture of safety, a culture of whatever you want it is that you want to call it, we need to understand what is in place today. There was a study done by the Harvard Business Review about a year ago looking at the different cultures that exist within industries. And they came up with 8 different characteristics of culture. And all of them interplay with each other. No one is unique in only one category. But they gave the example of a culture that is safe. And in their terms, safe meant that this is a culture that doesn't take any risks. This is a culture that follows the rules religiously without ever bending those rules. This is a culture that doesn't do any innovation. When we are faced with going into an organization that has that kind of a culture, and we now tell them we're going to change, we're going to use the model for improvement, we're going to do small tests of change, we're going to learn from what doesn't work well so that we can make it better, that becomes very threatening for that organization. And obviously that culture exists because the leaders in that culture are the ones who have fostered it and continue to foster it. To understand that gives you now the opportunity to figure out where do we go to be able to shape that culture. What are the things that we need to do? Why is it that people aren't willing to make the changes that are necessary? Why is it that they're really difficult to participate in any of the things that we want to do? And ultimately, unless we understand that, we will always be frustrated with trying to improve the culture of the organization we're working with. The culture that exists is the culture you tolerate. That is, as you work through any of the work that you do, you have to understand that whatever you tolerate is what happens. It's very interesting. I have an example from a recent visit to California. And as I was at the hotel, the water in my hotel room barely got warm. It was very, very lukewarm, if at best. And I went to the front desk and I said, excuse me, the water in my room is just not warm enough, and I just want to report that. It might be a problem with the heating system, etc. And his response to me was, oh, let it run for about 5 or 10 minutes. It should warm up. What struck me, though, was that in my room, there was a decal on the mirror that said, in California, we want to conserve water. Let's not waste water. Don't leave the water running as you're brushing your teeth or as you're shaving. Don't use your towel more than once. Don't recycle your towel once. So truly what they thought their values were the kind of values that in a state of California, which experienced some serious droughts, it's one of the states in the United States that really is pushing on conservation efforts, that they had those wonderful values. And yet the person at the front desk said, oh, just let the water run for a while. What's the message that's coming there? How many of your organizations put up values and say our culture is one of safety, and yet the people are allowed to take shortcuts? People are allowed not to follow the rules the way they're supposed to, or they just do and no one does anything about them because it's tolerated. I also want to bring in the fact that in order to develop a great culture, we also have to have staff that is engaged and is part of the work. There is nothing more damaging or challenging than having people who are burnt out, people who don't find joy in work, people who don't have a workplace where they can actually say, I enjoy going to my job and doing the right things. Because clearly, one of the things that you can ask yourself or ask your people you work with in the morning is, what kind of day do you expect to have today? And if the first reaction is it's going to be a terrible day, you know that everybody's going to be on the wrong foot to be on a terrible day. But the framework for the joy in work and an engaged workforce that IHI has developed, with help from lots of folks, including you in Scotland, is that we need to be able to provide real-time measurement, that is feedback to individuals. We need to ensure that people are well, Not only are they well by exercising and having time to meditate when they're not in the workforce, but even having space while they're at the workplace to be able to decompress or just relieve some of the stress that exists there. People need to be involved in improvement. That is, we all do our jobs every day, and all of us find that there are better ways to do the work. And yet we feel challenged when we're working somewhere that doesn't allow us to improve that. And it gets frustrating because we then don't do the work that we're supposed to be doing it in the way that we're supposed to be doing it. I mentioned earlier the importance of teamwork and how important it is to have teamwork and comrades that you work with, people that are your friends that you can count on. You need to be part of the management system, being able to provide input and co-produce the materials and the work and the processes that need to be done. And, of course, engaging patients in that co-production is also important. Recognition is important, and recognition isn't always a financial recognition or a bonus or an incentive. Sometimes recognition is just calling someone out and letting people know that you did a really good job. The IHI culture, as Jason I'm sure will attest to, is that when we start with staff meetings, we always have the opportunity to recognize people who have been doing some fantastic work in front of everybody in the organization. Autonomy and choice are also critical. We need to have an environment that has flexibility in the daily lives and work, especially now when we consider how much the electronic health records, for example, are impinging on our ability to do the work the way that we were supposed to. I have a philosophy about technology. Technology should support the work we do, not drive the work that we do, because right now most of the technology that I've seen implemented forces you to do things in a particular way, not necessarily supporting what is the right way for you to do it. Meaning and purpose is important. It's great to refer back to why did you get into healthcare? What is the work that you're doing? Most of us get into healthcare because we want to help other people. And yet we wind up in jobs that make it very difficult to do what we were really called for and wanted to do. And of course, psychological safety and physical safety are important. And at the center of our circle, we have engaging patients and families. And in the next iteration of that circle, we will have engaging staff and patients and families, because we believe all of that is critical for success. Now you said, Frank, you started with one framework and then you introduced another. Well, the Joy in Work framework, I think, is only going to be something that you can implement if you have the larger framework for safe and reliable and effective care. And by the way, call this the framework for improvement, because it is necessary for anything that you want to improve. Whether you're trying to improve flow or whether you're trying to improve harm and reduce harm, whether you're trying to improve access to care, all of these components become really necessary to be successful. So as you're trying to develop more joy in work, think about the role of the leaders. Think about developing that psychological safety. Think about helping people learn how to do their job and do their job well. Think about how to foster teamwork and improve communication. Think about how to engage others. Think about giving them an improvement method that will work, giving them opportunity to learn and develop reliable processes, and be transparent and honest in your communications. Now, there are three things that people in the workplace really believe that are necessary for them to be successful, and this has been studied by a number of folks. And one of them is my supervisor cares about me and my growth and development. At the IHI, we have these pulse surveys where every quarter we send out a series of questionnaires to a representation of the staff. We don't do the entire staff each time. And one of the main questions is my supervisor cares about my growth and development, because we believe that's essential. That if you are in a place where there is no opportunity to grow, no opportunity to better yourself, then clearly you're going to be frustrated and want to move on. I have the opportunity to develop and grow my skills. We all want to improve and want to do better. And we need an opportunity to be able to then do that and then continue to develop and use those skills that we have. We oftentimes encounter organizations that want to teach everybody about all of the safety work that we have. For example, everybody should take all the courses in the open school that IHI offers, and then they're never given the opportunity to use those skills to improve the work that you're doing. It's a waste of energy and time, both for the individuals as well as for the organization as a whole. And then there's the last piece, which is I have friends at work. And it could be a friend or multiple friends. And really, if you work in an environment where you don't have any friends, where you don't have any people that you can talk to, people that you can share things with, it becomes just an exercise of going to work every day and becomes really frustrating in trying to get that done. I ask you to reflect a little bit as you think about this. Consider a relationship that you have with someone. How much are you willing to share about yourself with that person? How much is that person willing to share with you? Why is that a strong relationship? And as you think about those relationships, the ones where you feel that you are just not going to share something with someone is really not a strong relationship. It's probably just an acquaintance. Whereas one where you have a deep ability to share something that will make you vulnerable by sharing it means that you have trust in that person, and that person has trust in you. And as we go through the rest of the presentation today, we'll continue to build on that a little bit. Now, why are we picking on trust? During one visit in an organization that we were looking at, there was an issue that came up during one of the site visits. And by the way, the site visits that we do to diagnostics are all based on the framework that we have. And we go through each of those elements and look at the behaviors and what's going on in the organization. That tells us quite a bit, more than just asking people questions. The behaviors and what people do really are much more telling. And what we found was that there was a clinician that wanted to admit a patient to a particular ward, and the manager of that ward said the patient doesn't meet the criteria for that patient being admitted. The manager then went off to a meeting, and while the manager was away, the doctor managed to get the patient admitted to that ward behind the back of the manager. When the manager came back from the meeting, the manager was surprised to see the patient on the ward after they had had the discussion. And the first thing we said is, what kind of trust exists between that doctor and that manager, where one of them was standing and saying one thing and the other was saying the other, and were they actually in it for the best interest of the patient and coming to a resolution based on what they thought would be best for the patient, rather than just standing their ground of one saying, yes, this patient needs to be admitted, and one said no. And we thought about that, and we thought about how much that must have eroded the trust that existed between the workers, and how people develop workarounds just because the rules that are in place aren't rules that make sense for the patient, and people don't trust each other to do the right thing. We then asked the leaders of that organization during the debrief whether or not they had trust in their own, amongst their own group, their own leadership group. And there was a pause and reflection, and one of the leaders spoke up and said, we don't trust each other. So how can leaders in an organization make decisions that will impact patient care and impact the work of the staff if they don't trust each other in making the right decision for the organization? The lack of leadership trust is also one that causes individuals now to have the opportunity to, again, not be able to pick the right goals, not be able to engage people in forming the vision and following that vision of the organization. The staff doesn't have trust in them, doesn't believe in what they're saying, because they may be putting up these signs and may be talking about these great goals of providing best care for patients, but yet what they actually work on and what the values are have nothing to do with that at all. Lack of trust also leads to poor relationship among staff and patients, and I'm going to spend a little bit more time talking about developing trust with patients. And that lack of trust also means that without that, how can you have psychological safety? How do I be able to speak up if I don't trust that the people I will reveal my anger, my frustrations, my lack of knowledge, my inability to do something, which is all things that we ought to be able to say candidly rather than trying to do those things where we are then putting ourselves and our patients in a difficult situation. If we don't trust that the people we'll say that to are going to be responsible and be able to manage that. Trust is foundational to the development and the maintenance of any relationship. And as I said, if we are going to trust each other, then we can do the work. But if we don't trust each other, then it becomes difficult to be able to maintain that work. Any successful organization, any successful sporting team, any successful military team is only successful because they are able to trust each other, that they can count on each other being accountable and doing the things that are necessary. So trust basically starts with me, and we talk about the role of leaders, but here you are a leader, and every one of us should reflect on what is it that I'm doing to build trust. Am I respecting the space of other individuals? Am I being responsive to people when they ask for help? And how is my response? What do I do? Am I being authentic in what I say and do? Am I being transparent in being able to share and provide feedback in a good way? Do I have constancy about what I say and do each and every time so that people know that I'm reliable and I will follow up on what I believe is important? What trust is choosing to make something important to you vulnerable to the actions of someone else. That is being able to reveal yourself. Remember when I asked you for the reflection, what are you able to share with others? Because you may be sharing something that you may feel threatened if you tell someone else who is not a friend, not someone that you trust. And it's a firm belief in the reliability, truth, or ability of someone or something that is going to work in the right way. You are going to hear from Brene Brown more about some of the work that she's done. And she's done a really nice work around the anatomy of trust, and looking at the boundaries, looking at reliability. And by boundaries, we mean knowing the limits of your friendship. Reliability, being able to be counted on by friends. Accountability, acting in the best way in the best interest of your friendship. Having a vault, that is knowing that what you have and what you learn is maintained and not becomes a tool for you to take advantage of somebody. Integrity in the work that you do. Ultimately, being non-judgmental. That is, each one of us is different, and each one of us has our own view, and we really should not be judging, but really trying to understand why that person has that view. And generosity, being able to be generous with the skills we have and our time and our efforts. At the IHI Health Alliance Europe, the leaders have gotten together and developed a sort of driver diagram that looks at all of the things that are necessary to support quality improvement. And the things that they focused on included creating energy, that is shifting from we're too busy for quality improvement to quality improvement is what we do every day. Creating trust, that's an important aspect, and I think that's one of the key elements of what we're talking about. Lead with humility, that is, we are not heroes. We should all be working together. We don't have to have all the answers. The answers come from us as a community to work together. Shift from positions of authority to putting power to let the others in the workforce, the others we work with, be the ones who can actually lead the work to get it done. Creatability, that is, that in order to improve, we need to allow people to use the skills they have and provide other skills rather than just holding them accountable for the things that don't go well. Celebrate and find joy in learning. Shift from the fear of failure. There's a great book called Turn the Ship Around. It's about a captain who took over a submarine, and he talks about the culture of avoiding failure. Avoiding failure is very different than improving processes. Avoiding failure is just that culture that is, quote, safe, not risk takers. All they want to do is make sure nothing bad happens, but do nothing to improve the systems to make it even better. Develop personal resilience. That is, instead of focusing on others, develop your own resilience, because you cannot be helpful to others if you are not helpful to yourself first. And create networks. There is lots of learning that goes on from all around the world, all organizations. The IHI model, as you heard me say, is all teach, all learn. We can all learn from each other, both from what doesn't go well, but also what has gone well. Edgar Schein has done a lot of work when he talks about helping, and his book, Helping, How to Offer, Give, and Receive Help. And the takeaway from the book that I see is that when someone is asking for help, they are very vulnerable. That is, they're putting up forward that they need help, and they don't know exactly what to do next to be able to solve their problem, to move on to the next step. And the people who are offering that help also have to be very much aware that they need to be humble. They can't use that ask for help as a launching point to say, I am better than you are because you're asking me for help. That in order for us to work together, we have to be able to trust each other to say that if I ask for help, that you will treat me equally, you will treat me well, you will give me what I need to be able to be successful, and I will trust you to be able to work with me and help me develop the skills and the tools and whatever is necessary to solve the problem that I have. I want to move to trust to patience, because we know that when patients trust their providers, their care providers, that there is opportunity for better outcomes. And that comes because patients are more likely to be open and disclose information to us. They are trusting that we are not going to ridicule them for maybe taking herbal remedies when we may not believe in them. We may be able to talk to them and have real conversations about choices, what matters to you, and not put them down and really respect that and work with them. Patients have perceptions of better care when they trust their providers and the people they talk to. And there's a greater acceptance of the recommended treatment and adherence to that treatment. That is, one of the things, I'm a pharmacist by training, and one of the things that I learned early on in my work, that in a community pharmacy especially, if a patient came to me with a prescription for a particular medication, and my reaction to that medication would be one of surprise, or one would say, why is he giving you this medication? The reality of that person actually taking that medication or trusting that it's the right medication suddenly drops tremendously, because I created that doubt, or I created that lack of trust that needed to exist between the providers of care and the patient. So our ability to trust each other, and by the way, pharmacists and doctors and nurses for a long time had very high levels of trust with their patients because they were able to focus on the patient and build that trust that exists between the two. And of course, patients who trust their doctors will have less anxiety about the treatment that is being taken. Patient trust really is more than just measuring patient satisfaction. And if we think about what it is that the patient believes are problems with the system, they really don't have a lot to do with harm. Yes, patients don't want to experience harm, but most of them think about processes and environmental issues. That is, that long delay in getting treatment. That is the wait in a waiting room to see the doctor. That is their inability to be able to get the treatment that they have. That is their being in a place where it is not private if they wanted to share information, an environmental issue, where if the environment is dirty, the message that sends to patients. What patients expect from us as providers of healthcare is competence and knowledge. That is, they want to know that we know what we're doing. And is full transparency, if we're uncertain, that we express that. And we work with patients to find the right treatment plan for them. We also, patients expect from us that we have good communication skills, that we oftentimes speak in medicalese and we use language that patients don't understand. And it doesn't matter how well educated you might be. If you're not a healthcare professional, many of the terms that we use in healthcare are alien to those folks. And I had that experience when we were working with the Massachusetts Institute of Technology Health Center, where they had made recommendations for one of the professors of economics to go get a colonoscopy because they were concerned that he might have had colon cancer. And the way that it was said to him and the importance and the urgency was not conveyed in a way that made sense to this professor. Yes, a very well educated person who teaches economics, etc., but not somebody who understands medical language and the importance of some of the tests that are necessary. And that really showed that no matter what your education level, literacy becomes a real issue. Patients expect honesty from us. That transparency piece, that we are honest with our patients in the treatment options that they have, and also if something bad happens, that we are honest with them about what happened. They are definitely interested in confidentiality and the caring that patients receive from their doctors. The What Matters to You campaign is one way that we show that we care, that we are interested. Now we have to follow up on that. It's not enough just to ask. And of course, showing respect for patients. At Beth Israel Deaconess Medical Center here in Boston, they are now pursuing disrespect as one of the harms that we need to deal with. I ask you to reflect before we move on to say, what is your workplace like? Is there trust? Do people have joy in work? Are people able to speak up when they have a concern? What do you have to do to build trust amongst your staff? What are the behaviors that exist in the organization that erode that trust that exists? And what do you have to do to build trust with patients? How do you now reinforce that trust with the patients who come to you because they're vulnerable, because they need help, because they're asking for you to provide the care for them that they need? I realize that sometimes patients may ask for something that we as clinicians may feel is not the right thing for them. That is where we as clinicians have to use our ability to communicate and to share, and now be able to help them understand why we're making a particular recommendation for treatment. With that, I say thank you for listening, and I look forward to questions. And I think, Arvind, you're going to have the very first question.
Thank you. He is in a moment, Frank. Let me first of all thank you for your contribution and your time. It will reflect in a little bit when people ask some more questions, but it's interesting when I'm not sure a few years ago if you'd been asked to give a talk on the latest thinking in patient safety, you would have gone immediately to trust and the workforce and patients and families and joy, but that is now where you go. I think that's the right thing to do, but it's interesting how that culture has changed over the last few years, that's where this talk has taken us. So I'm very grateful for that contribution. Thank you for doing it. And Arvind, you're going to ask our first question, and then others, if you want to type into the box. Too many people to hear all your voices, but I will do my best to take some of those questions in the last 10 minutes or so and ask them to Frank. So, Arvind.
Thank you very much. Yes, Frank, fantastic talk. Thank you for that. My question relates to some of the stuff that you talked about in terms of safe and reliable care, but what we see in everyday practice. So it seems to me that much of the work that we do for standardization and innovation results in NHS staff spending a lot of time on audits and checklists that sometimes duplicate work, often do not have an impact directly on teamwork, and may well generally add to ineffective work. So how would you advise organizational leadership to review, rationalize, and reduce unnecessary measurements and support further innovation and improvement?
Great, thank you. Great question, and good to hear your voice again. I want to be very clear that audits are necessary. However, our over-reliance on audits is what really creates the problem. So audits are necessary because every organization needs to know whether or not they have systems in place that are working. However, the audits are not necessarily quality improvement. In one of my visits to one of the countries, there was a room of about 50 people, and every one of them said to me, "I'm involved in quality." And I said, "Great, but what does that mean?" Basically, they were all auditors, and quality assurance requires audits. We need to be able to determine something is working, is it being done the right way. However, going back, we over-rely on it and don't understand the relationship between audits and quality improvement. When you do an audit, it really is something that tells you whether or not it's working. And normally what I see organizations do is yet another audit afterwards without really making any changes or improvement. So we tend to focus on the Duran trilogy, which says quality planning is the first step, being able to understand what is it that the customer needs and wants and what can we provide. You then put a system in place. The audit tells you whether or not it is working that way. When it's not, you go to improvement. Now, going back to what you said is that you try some innovation and suddenly you're spending more time on audits and more time on measurement. Again, it's understanding the role of measurement. Measurement for improvement is just enough measurement to understand if the system is working. And once you've reached a level of reliability that is at least 95% reliable, and we can go into the statistics of how many data points you need and all that, it then is no longer necessary to audit every week, every month. You can audit less frequently. However, you still need to be able to look at your system periodically. But the audits also need to be strategic. They need to be done on those things that are very important to ensure that you have the right outcome. And the right outcome is what we should be measuring all the time. Because you could always be looking at your processes and have very reliable processes, but if you're not achieving the outcome that you want, then you don't have the right process. The last is the use of checklists. I think we are overusing checklists because it seems to be the easiest intervention to put in place. I know that in many root causes analysis, one of the first reactions that we see is more training and education, or write another policy. I think very soon we're going to see write another checklist. Checklists are necessary, but only up to a point. The use of checklists we've learned from Dr. Gwande's work, and if you look at the airline industry and their use of checklists, their checklists really are a challenge because they say these are the essential things that we need to do, and the way they use the checklist is not the way we use checklists. Pilots don't have tick boxes. Because we create checklists with tick boxes, now it becomes a tick box exercise, and everything becomes a checklist. As I work with teams, the solution isn't a checklist. Sometimes the solution is really understanding the root of the problem, because if we fix the root of the problem, either we find the best way to do something to make it difficult to do the wrong thing and easy to do the right thing, or we don't wind up layering all these other processes that make it much more complicated. And all of this comes back to trust. That is, are we trusting the people at the front line to do their work? Are we trusting people to be able to find the right solutions to the problem rather than us dictating what those solutions should be? So in summary, audits have a place. However, the number of audits becomes really critical. Measurement for improvement is different than an audit, so knowing that difference becomes really important. And instead of just adding another checklist, let's really try to understand what the real problem is. And then if we fix that, we may not need to have checklists and double checks to make sure that it's happening. Arvind, any follow-up?
No, thank you, Frank. That's really helpful.
Frank, thank you, and Arvind, thank you for joining us, and thank you for the work you do in medication safety across the country for us. So, Frank, there's a number of questions in the chat box. The other thing that's happening in the chat box, for those of you who are paying attention, is there's quite a lot of resources. So, as Frank mentioned stuff, we had very elite internet Googlers finding that stuff and putting it in the chat box. So all of the frameworks Frank mentioned, the articles he mentioned, the book he mentioned, are all in there if you wanted to note down those links. Save the chat box at the end if that's something you want to do. So we've got a few minutes, Frank. Fiona Montgomery, who is the head of the leading improvement team in Scotland, who you know relatively well, Frank, she's asking whether you think the safety framework could perhaps be expanded and used across other public sector areas, maybe outside safety, but also outside health and social care. Fiona's responsible across the whole of Scotland's public and third sector. So think of education and the fire service and even Scotland's national parks. Do you think there's something in that?
Yeah, thank you, Fiona, for that question. And what I've been looking at now, and as I said during the time that we had together, is I think if you strip off the part at the top, the title, the Framework for Safe and Reliable Care, and you call it the Framework for Improvement, those elements are necessary everywhere. And the work that you in Scotland have done around improving services outside of healthcare, looking at the social sector, all of those things become really important. Because leaders at all levels of the organization have to believe it's important. You have to create an environment where people can work together. You have to have an environment where there is psychological safety, because you don't have teamwork unless you have psychological safety. You don't have psychological safety and you have teamwork, and both of those are built on trust, that we have trust in each other. So yes, I think it has an application throughout all of the work, and foundationally we also have been looking at whether or not the elements of the framework are the guiding force that allows an organization on its journey to high reliability. You may have heard the term high reliability organizations, because the characteristics that we know of are characteristics. There is no one formula on how to get there. But I do think that the framework allows you to have the skeleton upon which you can build no matter what kind of work that you're doing.
Thanks, Frank. There's a couple of quite practical, hard questions. Well, I think they're hard. Maybe you won't. How do you get over the difficulty in challenging upwards? So how do people? Jackie Welsh asked a variation on this question, and there was another one earlier on. from Ayrshire and Arran in Scotland. How do you challenge when you see something in a culture that perhaps isn't what you believe the value should be?
That's a very interesting question and discussion because it is managing up. We did an exercise with one group that really asked, what is it that you need to do to engage your leader? And in order to engage a leader, you need to understand what's important to your leader. And again, this is an exercise that we've tried several times. It is a different approach that we've tried to take, where basically if you think what leaders are most worried about, and if whatever it is that you're finding as an opportunity for improvement, I would say that first is play to that leader's interest, figure out what it is that the problem is that you're trying to solve, and best of all, don't be another problem that the leader has, but offer a solution or an opportunity of something that you can try to be able to make that better. I give you the example of my son. My son works at a clothing store here in Boston. And in the time that he's been there, he's found lots of opportunities for improvement. And he's wrote a nice summary of all the things that he thought were problems. And after each one of them, he put in what he suggested would be something to try, to whether or not that would be something better. And of course, all of it led to they wanted to have a more efficient showroom. They wanted to be able to have more sales, things like that. And by building it that way, the response that he got from corporate was, no one has ever approached me this way. This is wonderful. I wish all of my staff would be that way. So does it work for everybody? No. But I think if we can understand what it is that really pushes their buttons, for lack of a better way to phrase it, we can approach them and offer something that we think might be beneficial.
Christine McGregor, who works in the Scottish Government, says, what about the real method underneath this? So what about improvement and measurement? So frameworks are all very well, but what do we do to actually implement these changes?
Yeah, so improvement and measurement are part of the framework. That is, they're part of the learning system. And improvement, so let me just take one step back, especially in the area of healthcare. I think that when I go into an organization and I hear we have a patient safety project because we're trying to improve safety, I struggle a little bit because when they say project, to me, a project means a beginning and an end. And providing good care to a patient is something that we do every day. It doesn't have a beginning and an end. And when I am told we're doing a project on central line insertions, it makes more work. I look at it very differently. What we're trying to do is we're actually trying to help you do what you should be doing right in the first place. However, we do need to know how to approach improvement, because if we all knew how to improve, and I've been on this journey now for a long time, I don't think we would have fixed the problems a long time ago. So we do need some way to help us understand the problem. We do need some tools to dig more deeply. We do need some tools that help us to figure out how to change things and test them to whether or not they're actually the right things before we invest too heavily in an organization and then work in a policy and whatever it is. And then we need to encourage people to have a different set of eyes to be able to continually look. Measurement is important. Again, how much measurement, though, is the issue. Because if we spend more time measuring, then we don't have enough time to be able to do the work we should be doing. But sometimes measurement can be very easy. You have helped us pioneer the safety calendar, and how quickly on a ward, just by using the safety calendar, you can determine whether or not things are going better or not. Yes, there is a need for that bigger measurement that organizations need, but that's not measurement for improvement. That's just measurement for reporting, measurement for quality assurance. So it's a blend, but ultimately you need to have the skills, the time, and the place, and also the attitude to look at improvement not as something special, but as something that we do every day.
Frank, we're not going to have time to do them all. A question that quite often comes up, and you've spent a bit of time in Scotland now, and Scotland and to maybe a lesser extent some of the English communities and the other UK countries, frankly struggle with the language a little bit of joy in work. So Anne Forsyth and a couple of others have intervened. I see Simon giving a suggestion. Are saying, have you come across in other countries other terms for joy, other ways of describing the joy and work framework? Simon Edgar says that in Northern Ireland they're saying enjoying work is what they are doing, and the same at East London seem to be doing it. Joy and work it just doesn't resonate somehow with some of our communities.
Yeah, that's a wonderful question, Jason, because anytime we have one of these frameworks, it's really, we need to understand the words and the context in which they're being used, because joy in work is something that's common in the United States, and I would actually say that maybe we should be changing it to enjoying work as well. Most of the pushback, and I wouldn't say pushback, that's not the right word, but most of the comments about changing the title have come from the UK countries. And a lot of it, again, is the context in which the words are used and the meaning that those words have. In other parts of the world, I don't think yet we've gotten to the point where they have adopted it as much as we have in the English-speaking countries. So I don't have a lot of other things. We tend to use joy in work, but again, it's probably more of a consultant buzz term that we use. I just think passion of work, or being able to go to work and do what you really want to do, is really what we're talking about.
You've even got your slightly morose Scottish chief executive to talk about joy and work. I've seen him on a stage talking about it. That wouldn't have happened when he lived here.
Yeah.
So Frank, let me again, just as we come to a conclusion, thank you very much for your time, for your insights, for your answers to the questions, and I'm sure you're willing to continue that conversation online and in other places if people have more questions and want to engage with you. So thank you very much. Online webinars don't lend themselves to applause because we have everybody shut off, and it feels a bit weird to have that silence, but take a bow, Frank, and we thank you very much for joining us.
Thank you for the opportunity, and for all those on the call, thank you for all you do for patients. You know, we may never know the patients that we help, but it's just knowing that we are making a difference is wonderful. So thank you for all your help.
One final advert in the last 60 seconds, and that's for our next QI Connect on the 28th of May. We don't often bring somebody back. In fact, I don't think we've ever brought somebody back. Even I didn't get to come back. But this is Brené Brown's second QI Connect because she went down so well the first time. We've invited her back and she's kindly agreed. This time we're going to focus on her new book, and she's going to specifically hold a conversation around that new book, give us some segments of it and her insights into it. It's called Dare to Lead. You might want to read it if you have the time to do that before she comes. But on the 28th of May, we'll hear from Brené Brown. And that leads us into this whole year's set. And we didn't line this up, Frank, but we have in September, we have David Marquette, who is the guy who wrote the Turn the Ship Around book. So we're looking forward to that. Those of us who have read it will be interested in his insight. And you can see the other leaders there as the year proceeds. So it just remains for me to thank everybody for joining us, and please continue on Twitter if you have any questions for Frank or for the rest of us. Please continue to do that, and we'll see you and hear from you in May.
Okay, that's great. Frank, are you still on the line?